Hi everyone, welcome to the Virtual Infectious Disease Congress, sponsored by Johns Hopkins University School of Medicine and ID Care Live. My name is John Bartlett, and you are tuned into a live CME session called Emerging the New Era of Hepatitis C with Dr. David Thomas, who is Professor of Medicine and Epidemiology at Johns Hopkins University Schools of Medicine and Public Health, and Chief of the Division of Infectious Disease at Johns Hopkins University School of Medicine. Before we get started, I'd like to remind you that we are taking questions in real time throughout the presentation. You can send us your questions during the program in the box on the lower left-hand side of your screen. We encourage you to do that. We'll answer the questions either as they come or at the end of the program. So I guess we ought to get started, and I might start the dialogue here, Dave, by saying, well, I'll answer the first question, which has already come in. The question is, do we have expectations to when the protease inhibitor treatments without PEG interferon and ribavirin will be available?
All right, that's a good question. I was going to start out on, in May of 2011, 2 new drugs were approved for the treatment of hepatitis C, boceprevir and telaprevir. And those drugs are protease inhibitors that are, interfere with HCV viral protease. They were the first drugs that we ever had for treatment of hepatitis C that actually worked directly on the virus itself, as opposed to augmenting the body's own immune system. And the first drugs we had new drugs since 2002. So those 2 medications, those protease inhibitors, are used together with pegylated interferon and ribavirin, either of them. And they're approved for use in persons without HIV who have genotype 1 hepatitis C infection. The question is probably oriented towards when would, so they're commercially available right now. They're being used all around the country, in fact, all around the world. The question of when they would be approved for example, persons who are duly infected with HIV is a good one, and we're still more than a year away from when we would expect them to have an FDA indication. And in some instances, that's made a difference in terms of their availability for use for a patient that has both HIV and hepatitis C. But it is important to know that, that those medications are already available right now and being used around the country for persons with just hepatitis C alone.
So the question about unloading interferon and ribavirin is a really good one. And I guess one of the key questions is it now or later? And can you address that?
You're right. The holy grail for hepatitis C treatment has been to cure someone without interferon. Interferon works, but it has to be, it's difficult, it has to be injected, and there are a lot of side effects. And for many patients, interferon's been the chief obstacle to taking hepatitis C treatment. And it's not just the patients. There's providers that are just uncomfortable with any kind of treatment regimen that involves use of a biologic that they haven't been trained to use. And so there's tremendous interest in interferon-sparing hepatitis C treatments. And fortunately, there are already phase 2 studies with no interferon that have shown that individuals can be cured, and not only can be cured, but we were looking at the liver meeting last month, we're looking at success rates above 90% for curing hepatitis C without interferon by using combinations of direct-acting agents that protease inhibitors, nucleotide inhibitors, NS5A inhibitors, combinations of these plus or minus ribavirin That's really where the field is headed. And it's possible that although the individual medications will be approved in about a year, the combinations, the interferon-sparing combinations, we're probably looking, or just entering into phase 3, so we're probably a couple of years still away from having an FDA-approved interferon-sparing regimen that's available for use.
So this would be all oral. It would be going for cure, and it would be successful perhaps up to 90% of the time.
That's what we're looking at now. Now, we're talking about, just once again, we're talking about pills, all oral, more than 90% success rates, and 12 to 24 weeks of treatment, eradicating hepatitis C. No relapses, reductions in the risk of liver cancer, reductions in the risk of cirrhosis and decompensation of cirrhosis. All the medical benefits that you hope would come with treatment being realized without interferon and with perhaps as little as 12 weeks of treatment. Now, there's no question in principle that that will occur, and there's no question that that's inevitable. When I say success rates above 90%, I need to be cautious because these are phase 2 studies. These are some of the easiest to treat patients. They don't, in most instances, have cirrhosis. They don't at all have HIV. They're among the easier to treat patients, and our experience tells us that there'll be a drop-off when we get to sort of real-life, real-world situations. But nonetheless, that's what the excitement's about, and it's coming a lot faster than any of us ever thought.
So back to my original question. So I see a patient that has hepatitis C. I have drugs that I can give him now, but it'll be painful. How do I decide whether to tell him, you should really wait? How do I make that decision? To me, that's a hard decision.
Well, it's funny because I've heard people ask you before about whether you should use vancomycin or Flagyl or metronidazole for treating C. diff, and you've said, you know, it kind of depends on whether it's your mom or your mother-in-law. And you know, I think that in all seriousness, what the simple answer is, for most experts right now, if somebody has low-stage disease, so they have little liver fibrosis or minimal liver fibrosis, it's certainly worth the wait to go on, to wait a couple years for the interferon-sparing regimens. For an individual with cirrhosis, where there could be a consequence to waiting, where the patient could decompensate in the 2 years that you're waiting, that's a different situation. And I think what a lot of us are doing in that instance is going ahead and beginning the treatment. But our threshold for stopping it has shifted. It's shifted because we have the confidence that we might have a backup plan. So if the tolerability drops, or it looks like the efficacy is going to be low because the viral load's not coming down very fast, we might be a little bit quicker to stop treatment now, even now, with the knowledge that we've got a backup plan coming down the road.
So it's interferon for your mother-in-law, and it's DNA.
You know, you're a lot more experienced with these kind of things than I am. And I realized halfway through that I probably shouldn't have said it because we were being recorded. But yeah, and I really like my mother-in-law, so I'm actually I'm going to change it around and say interferon for the person with cirrhosis or who has significant liver disease, and you think the safety of waiting just might not be sufficient. And for everyone else, I'm doing a lot of waiting, to be perfectly honest.
So for the issue of the cirrhosis in the decision, you really need a fibrosis score to do that, don't you?
You do need some measurement of liver fibrosis, and you need that to take care of a hepatitis C infected patient, no matter what you're going to do with treatment.
Okay.
Now, why is that? The reason is that if your patient has cirrhosis, you've got to look for hepatocellular carcinoma. You've got to do hepatocellular carcinoma screening and look for varices and manage the patient as a cirrhotic. And that's without regard to whether you're going to treat them urgently or not, and without regard even for the success of treatment, because we continue hepatocellular carcinoma surveillance even after curing someone with cirrhosis. So you need to find out if they have cirrhosis. Staging can also give you information, as I've already mentioned, on the urgency of the treatment. Mm-hmm. So it gives you those two things. The question is not whether to stage, it's really how to stage. Yeah, you were right with me on that. So it's really how to stage right now, and the controversy comes down to the biopsy. Okay, and there's accumulating evidence that whereas the non-invasive testing might not be as reliable as you'd like for discriminating subtle differences in the amount of scarring, let's say stage 2 versus stage 1, for example, that they are, however, very good at finding cirrhotics. And so if your objective for non-invasive testing is chiefly to find cirrhosis or not, you can use the non-invasive test with a high degree of confidence, and then push your your decision about the urgency of treatment to include many other factors, such as the really where the patient's at, their readiness for treatment, and those sorts of issues.
When you say the non-invasive, you're really talking about FibroScan or FibroSure?
Right now, in the United States, what we have are some blood tests. One of them, for example, is the FibroSure that you just mentioned, that you can order through LabCorp and some of the big commercial labs. Most of the big commercial labs have that or some other algorithm-based test that involves multiple individual analytes, and their results are kind of grouped together to discriminate persons with their degree of fibrosis. They give you a score that tells you stage 1, 2, 3, or 4. They're not so accurate in the middle, but unlike a liver biopsy, you can keep doing them every 6 months. Yeah. And I find that if you have a sustained pattern of low results, for example, they're very secure, and I feel very secure using those on the patients that I'm waiting for interferon-sparing regimens. And I just keep ordering them every 6 months, and making sure that person has a low FibroSure score.
Now, let me get back to sort of the bigger picture. What's happened to hepatitis C is, to me, really an extraordinary event. And yet we don't really, all the hooplas about AIDS and the end of AIDS and treatment for prevention and, the headlines. Hillary Clinton gave a speech yesterday about this. There's a plan. There's a big national plan for this. And a huge amount of hoopla. And yet, hepatitis C seems like it's bigger. It's as important or more important in a lot of ways, globally, nationally, and yet sort of getting to the goal line is a lot closer, like about 99 yards closer. You want to comment on that?
Well, that's a great observation, and you're uniquely able to make that from your perspective in the field. You're right. There's no question that, first of all, hepatitis C infects 3 to 4 million, maybe as high as 5 million persons in the United States, depending on how you count. It has already passed HIV even as a cause of mortality. In 2007, it passed HIV as a cause of mortality in the United States. And at the same time, we've got these treatments coming that can eradicate the infection. Our holy grail is here. And so it really is surprising. It's interesting. The virus has survived for a long time by learning how to hide. And it learns how to hide out in cells and escape recognition by all those molecular mechanisms that are supposed to alert the body that there's an infection in it. And it survives in society by also staying below the radar. The virus has figured out a way to stay below the radar. And unfortunately, in the United States, there's just not the alarm and the shock that should be there to recognize the opportunity that we have to literally eradicate. There's no reason we couldn't eradicate hepatitis C from the United States.
But I don't hear anybody talking about it. I don't see that movement generating a lot of hoopla or press or. I mean, we just don't have that meeting end of the era or the AIDS-free generation. We don't have a hepatitis C-free generation, and yet it seems so much more doable.
It is. It's vastly more doable right now with the tools that we have. It's not. We're both infectious disease specialists. We both fully embrace the ambition of curing HIV and are thrilled to see the work that's going on there and the science that's coming and the hope of that AIDS-free generation. But in the meantime, we have this other opportunity right now to eradicate hepatitis C. And as you put it, it's shocking that it hasn't gotten anyone else's, it hasn't gotten the attention that it deserves.
So how many drugs are in the pipeline?
Well, it's an interesting question. How many drugs are in the pipeline? There are at least 6 in phase 3 alone. Right now, there's 6 drugs from 4 different classes in phase 3. Not to mention all of the drugs that are in investigation, phase 1 and phase 2, that may or may not survive. So it's an exciting time for sure.
Now, with HIV infection, we had a cadre of people that did it, called AIDS providers. They all went to the same meetings and had the same journals and so forth, and learned how to deal with resistance, about drug interactions, about monitoring and so forth. Is that going to be kind of the style for hepatitis C? Who's going to take care of the patients with hepatitis C?
You know, it's interesting. Let me put it this way. Imagine that you have HIV, but you go from 1996 to 2008 in a day. Mm-hmm. That's kind of what we might end up with hepatitis. I'm exaggerating, but what I'm saying is that we're going to skip a really protracted state of learning how to dose Crixivan and learning how much nalfinavir you have to take, and how, you know, and how to deal with OIs and all. And I'm not really seeing it taking that long with hepatitis C. And if we're going to be, there's a regimen, a 1-pill, once-a-day regimen that's moving into phase 3 already for hepatitis C. Now, I'm not sure how it's going to turn out or anything, of course, but so it may be that we skip the stage of having to make it exceedingly complicated before we get back to making it simpler. And actually, what we may see instead, because it's plenty complicated right now.
Yeah.
Treating with protease inhibitors and PEG and ROD, that's heavy lifting. It may be that we go right from that to a much simpler care model, where we're talking about 12 weeks of I mean, it's going to make hypertension look tough, right? Possibly. And so it may be that we actually see the exact opposite, and that hepatitis C treatment becomes something that is like treating syphilis or something else that can be done at the primary care level.
Really?
perhaps even at the public health level, although I sometimes get a bit ahead of myself. But we treat tuberculosis, we treat STDs, we treat some other infectious diseases where there's a disproportionate share in tough-to-reach parts of our population. We use public health resources to augment the primary care provider and specialist medical model. And in part, that's been possible because of the simplicity of treatment in those, and the safety of treatment in those, for those infections. I'm not so sure that we won't get there with hepatitis C, where you couldn't, for example, move treatment into a non-traditional venue like an STD clinic, a public health clinic, a methadone clinic, something like that.
Now, one of the things you have with hepatitis C is kind of what there has been an issue with HIV right from the get-go, and that is the people that find the cases are people that don't go to our meetings, don't go to the hepatitis C meetings or the HIV meetings. And one of the biggest problems with HIV was to get primary care providers to understand the need for testing people, even though they may not be perceived to be at risk. And I assume it's the same with hepatitis C. The vast majority of people that have it don't know don't know they're at risk or were ever at risk.
You're right. The folks that are worked up about hepatitis C are it's sort of like the preacher preaching to the choir, are not the ones that need to hear the message. And so it's estimated that for HIV, what is it, about 20% of people don't know that
about
they
20%.
have it. With hepatitis C, it's probably more in the neighborhood of 60% that don't know it. And that's a number that should shock us when we have a curable infectious disease that the treatment can save, save someone's life. The other number that ought to get our attention is that of the 40% that know they have it, more than half don't get treated. Don't want to get treated, don't get treated when they go see a doctor, don't have a contraindication for treatment for whatever reason. Very few end up actually on treatment. And so that's another part of the story that I don't think we've quite gotten our head around yet, because we think once we get to where you've gotten with HIV, with 80% of the people knowing, we'll have 80% of the people cured. We got to do something else different for that to be true. Because right now, there's a big drop-off from the ones that know it to the ones that are cured. Hopefully, interferon-sparing treatment will get us part of the way home. But I think there's more. I think we need to do something more to light a fire inside of people to make them want to get treated.
Okay, now I'm going to get out the dartboard and mention the U.S. Preventative Services Task Force and their recommendation of 2 days ago. Do you want to comment on that?
No, you're right on target. On Monday afternoon late, the U.S. Preventive Services Task Force revised their 2004 grading for screening for hepatitis C. And they embraced the idea that you should test persons with risk factors for hepatitis C and gave it their B rating, which means there's enough evidence, at least moderate evidence, to support doing it, and that essentially that's what you should do. Should be paid for. It's a good idea. Where the rub is that they gave a C rating to the recommendation that the Centers for Disease Control issued in August that said that we should test everyone born between 1945 and 1965 once to see if they have hepatitis C infection. They thought that that would find about 800,000 people who didn't know they had hepatitis C, and that even with today's or yesterday's treatment successes might save 120,000 lives. So the CDC said, let's do it. This is the right thing to do, and they added this. The U.S. Public Health Service Task Force, the U.S. Preventive Services Task Force didn't embrace that evidence and has, in their draft recommendation, given that a lower grade rating. It's not evident to date why and a number of vested parties, including my own personal opinion, have not understood that difference and have thought that the birth cohort should also get a B grade. For the same reasons that they gave a B grade to the risk-based testing. What difference does it make whether I used drugs 30 years ago or not when I can benefit from treatment? Wouldn't I want to know? Wouldn't you want to know if you had hepatitis C? And so the fact that I'm not a drug user or haven't used drugs or don't want to talk about that, why should that mean that my insurance company won't pay for my hepatitis C test? I can't understand that yet, and so I think we're pushing back a little.
I think I think one of the points that makes it particularly painful, as far as I'm concerned, is they did the same thing with HIV infection. So the CDC made their recommendation to test everybody between the ages of 13 and 65 in 2005, and then, or 2006, and then 2007, the Preventive Services Task Force went against that and said we should do risk-based testing. And this year enjoined the CDC recommendation from 2005, so they came 5 years later and 250,000 new AIDS cases afterward without any new information. I mean, we don't know that there's been any new data to support that, and we kind of wonder if it's going to take a long time and a lot of pressure to get them to turn over. I'm not sure. They invite comments and say these are drafts, so they may land on their feet. But right now, I'm not optimistic. I don't know if you are. I don't know enough about the task force and how they work.
Well, we're certainly, a lot of us are making comments. I'd encourage anyone watching this that feels likewise to make their opinion known. Look, the Preventive Services Task Force are not politicians. They're smart people doing their job, doing the best they can. And I think my best way of understanding the way this has developed is that if I get screened for prostate cancer and I get a false positive test, a lot of harm could come to me because of the biopsy and the consequences and all the testing. And they're trying to prevent me from suffering harm when there's not enough evidence to justify the testing. And I get that. And I'm glad they're doing that job. I'm glad they exist. I think the difference with an infectious disease is that there's no suffering that comes from getting a confirmatory test for hepatitis C. You just get your blood drawn, you find out if you really have hepatitis C or not. And if you do, you get the benefits of the treatment, and you might save your life. You might be one of the 120,000 people that gets their life saved. And I think that it's one of those situations where I kind of understand. It's not like the fiscal cliff politics that don't make any sense to anyone. I kind of think that it's just because they've extended this bias towards protecting us from unnecessary testing, but they kind of miss this nuance where we have a way of confirming HIV or hepatitis C. We don't need a prostate biopsy to find out if we have hepatitis C.
Yeah, we don't have false positives. We don't have them in HIV, and we don't have them in hepatitis C.
And we don't give chemotherapy to people with hepatitis C who didn't really need it.
Yeah.
That's not what's happening. And when we look now, it wasn't their job to look ahead to interferon sparing. That's not their job, because that hasn't happened yet. But when people like me look ahead to that, I think that there's a lot more chance that this recommendation is going to do harm than it's going to do good. And I hope that they think of the impact of their recommendation and the denial of payment and the denial of big managed care organizations that say, you know what, we're just not going to do it. We're not going to do the birth cohort testing because the U.S. Preventive Services Task Force says you don't need to. And says, hold on, maybe we got this one wrong. Maybe it ought to be a B. And I hope they change it. They've got about 21 days left.
Okay. So a lot of the people watching, or probably virtually everybody watching, does hepatitis C treatment or care in some way. But I think one of the things we need people to do is to extend the message to do the screening or to think about hepatitis C to people in primary care and so forth. So what should we be telling people? Should we say CDC recommendations recommend this for the birth cohort, anybody at risk, anybody with transfusions before 1992 and so forth? And then get a confirmatory test and then refer? Would that be the pathway?
I think so. I think you've got it right that the risk-based testing didn't work.
Yeah.
Or at least the people for whom it worked, they already know they have it.
Yeah.
So let's look for something new. And we need to find the new ones. We need to find the other 60%. And one way to do it is to test in places where you expect there to be a high prevalence. You maybe don't, and the birth cohort is one. But it might be the emergency department at Johns Hopkins. It might be an STD clinic. It might be a primary care practice in the Bronx where the prevalence of hepatitis C is 8%. In those kinds of settings, just test everyone. Find, opt in, don't opt out. Make it so that testing once is the norm. Confirm it with an RNA test, and then it would then be the people that are positive need to have some counseling about discontinuing alcohol, or at least moderating it. They need a hepatitis A and B vaccination. And the third thing they need is to have a discussion about not transmitting the virus to someone else. So those are the three parts of counseling and the three parts of early care. Hepatitis A and B vaccination, counseling about not spreading it to other people, and the alcohol cessation. After that, it's about, are they a treatment candidate or not, and find out if they have cirrhosis or not. And depending on someone's comfort level, they could be referred for that, or even have some of that testing done in a primary care.
And suppose I have a lot of patients well, I don't have a lot of patients, but I have some patients who say, well, I know I've got the hepatitis C, but my doctor tells me that I have normal liver tests. What do you do with that?
Well, the liver enzymes, as it turned out, aren't the best predictors of who needs treatment and who doesn't. So I don't think it's I think that using one of these non-invasive tests would get you a lot further, and quite frankly, if you get your result back and it's a very low stage, I don't think there's a problem then with talking to the patient about waiting and saying, you know what, I'm not going to send you to a hepatologist now because you can afford to wait. I'm going to every 6 months repeat these tests. As long as your results are low, we're going to wait till medicines get safer, and stay tuned. That's a very reasonable way to manage people. If they come up with a high result on their non-invasive testing, then send them to a hepatologist or an infectious disease doctor or somebody who does hepatitis C treatment for a living.
And then how about the cost of the treatment?
Well, it's cost of treatment's one of those things that it depends on your perspective. If you have a $5 copay, the cost of treatment is $5 a month. If you're responsible for a managed care organization and you're paying the bill for that $5 person, the cost of treatment can be more than $50,000 for a course. And the average wholesale price for the current treatment of genotype 1 hepatitis C infection is more than $100,000. When you add up the protease inhibitor, somewhere around $50,000 to $60,000, and the pegylated interferon, the ribavirin, and you haven't paid the doctor yet. So the cost is extraordinarily high. And when we start talking about getting practical, you and I began this conversation about, oh, we're going to eradicate infection in the United States. But who's going to pay for that? That's another another conversation.
Hey, one of the interesting parts about it is that with HIV infection, when you start to do the cost effectiveness, why then, you know, your testing now and your treatment now, it prevents a lineage of problems and hospitalizations and so forth for decades out. With hepatitis C, everything is, as you mentioned, compact, and your 50K is 50K for 1 year. So you pay all of the money up front, and that's exactly what payers don't want.
You couldn't be more right, and some people who don't get that don't understand. But I say to them, look, if you have a room of 10 people and you go up to the first person and you say, you have a choice. You can either pay me $10 now, or the guy sitting next to you can pay me $20 tomorrow. What do you want to do? The guy will say, oh. And you go to the next guy and you say, you can either pay me $10 now, or the guy next to you is going to pay me $20. You will get 10 out of 10 people. You know what you get? You get the healthcare system in the United States.
Yeah.
Because you can't ask one guy to pay for someone else's benefit so that someone else doesn't have to pay more later. And that's the situation we're in.
Yeah. Yeah, that's a big problem with the healthcare system that we've created. I'm not sure that we're going to be able to fix that in our lifetime, but that's sort of the system we're in. We're sort of stuck with. And how about hepatocellular carcinoma? We'll be able to pretty much eradicate that as well.
Hepatocellular carcinoma is, as you know, one of the only cancers whose incidence is rising. Mm-hmm. And you know, everything else, lung cancer, breast cancer, they're coming down. Colon cancer. Hepatocellular carcinoma, going up. Going up because, in the United States, hepatitis C. It's going up because it takes 30 to 40 years of hepatitis C before you get cirrhosis, before you get hepatocellular carcinoma. So if you don't do anything about it right now, hepatocellular carcinoma rates are going to double. And that's going to be a big problem. It already is, as people age and develop more cirrhosis, more liver cancer. If you cure someone, you reduce the risk that they're going to get hepatocellular carcinoma.
You cure hepatitis C.
If you cure their hepatitis C. But you don't eliminate it completely. Mm-hmm. And we have to keep monitoring them for years after the cure, because the cirrhosis, the scarring, the anatomic differences, the cell proliferation, that all continues even after the virus is gone, which is why we need to cure people before they get cirrhosis, because if you don't have cirrhosis, the risk of hepatocellular carcinoma related to hepatitis C, it almost comes back to the general population risk.
So Dave, we've got hepatitis B, we can't cure that. We've got HIV, we can't cure that, with one or three exceptions. Hepatitis C is different. Why? Why is it different?
Hepatitis C is different in large part because the virus has to continue to replicate to sustain its life cycle. It doesn't hide out inside of the DNA of the host cells in long-lived host cells like HIV can do, and even hepatitis B, which can integrate into hepatocytes and lay dormant in a very stable state inside of the nucleus of a hepatocyte. Hepatitis C can't do that, and actually has surprised all of us that you really seem to only need to turn off this virus for a few months to cure it, and to let the host finish the job and clean up on its own. So it's a different biology. It's a different infectious disease, and it's the one that we can cure right now.
So is anybody, getting back to where we started, is anybody actually talking about mounting a national or international effort to deal with hepatitis C, sort of with calling for the cure or the end of the disease?
Well, people like me do that, but not people that matter, not people that,
not Hillary Clinton.
People. Hillary Clinton and Secretary Sebelius, they're not talking about it, and perhaps Bill Gates is not talking about it. It's achievable. I think if Bill Gates and Warren Buffett wanted to do it, or if our federal government wanted to do it, it's achievable. It's an achievable goal. There would become a point. You're well aware of the studies that have shown that if you're successfully treating, not curing, but treating HIV, you can prevent HIV transmission.
Yeah.
So the same would be true for hepatitis C. If you are cured, you can't spread the infection anymore. And so there will come a time when enough people, theoretically, could be cured, that infection will just go away. And it will be completely eradicated in the way that occurred with smallpox. It's more likely, in my opinion, that it'll go the route of polio, where if you, in the places where there's enough money and health infrastructure, it'll be cured. It'll be eradicated. It'll be eradicated in the Johns Hopkins hepatitis clinic. But it might not be eradicated in East Baltimore. And that's the rub. And the difference is probably money and infrastructure to deliver treatment.
When you say money, are you saying, now I know HIV infection has really selected people below the poverty line like nothing else. Does this apply to hepatitis C as well?
There's clear evidence from the National Health and Nutrition Examination studies that hepatitis C disproportionately affects persons of low socioeconomic status, and they're sampling the people who have households. It's even more disproportionately present in inmates and homeless individuals who aren't even counted in those kinds of surveys. So the answer to your question is yes, and that will be a huge challenge when it comes to trying to eradicate it. It would be like as if with HIV, well, let's say you have meningitis, and I try to eradicate your meningitis by using medications that don't penetrate the blood-brain barrier. You would fire me. You would say, Dave, I thought you trained at Hopkins. Don't you know not to do this? And it wouldn't work. And in the same way, if we try to eradicate hepatitis C from the United States with medications that don't penetrate into the affected populations, it's not going to work. If we don't get them into the prisons, if we don't get it into the methadone clinics, if we don't get it, it's not going to work, and we're not going to eradicate. And they're going to continue to be infected and infect others, and that pattern will be sustained.
So there's a question here that may have preceded our discussion of prevention, which is prevention of hepatitis C. Do you want to say anything more about things other than treatment of those infected?
Well, there's an important, there are two key elements of prevention that I haven't even mentioned. The first being behavioral. stopping the practices that lead to hepatitis C, or at least reducing the risk. Needle exchange, preventing hepatitis C transmission from transfusions, those kinds of things are exceedingly important. They work where they're applied. Bloodborne pathogen standard has diminished transmission within healthcare facilities, that sort of thing. Vaccination. You can't talk about prevention without talking about vaccine. We still don't have a vaccine for hepatitis C. We could, but again, the contrast with HIV is startling.
I don't see how you're going to do the trial.
It won't happen because, well, I'm not going to, it would be challenging to get the resources to do it. There's a phase 2 study in Baltimore right now and in San Francisco to test, in principle, whether a hepatitis C vaccine would work to prevent infection in drug users. I'll be shocked if, even with the best outcome, it's picked up by a pharmaceutical company that will then pay the $500 million or whatever it takes to register a vaccine for phase 3.
Yeah. There's another question here about how do you know a patient is cured?
Well, the easiest way to tell if someone's cured is to check the hepatitis C RNA level 6 months after they've stopped treatment. For persons that whose infection is suppressed and undetectable during treatment, and then 6 months after they stop treatment is still undetectable, we talk about cure, because in those instances there's only a 1 or 2% chance that it would ever come back.
And then there's a question here about what do you think about targeting agencies such as alisporiv?
Cyclophilin inhibitors like alispirivir. So it's interesting that some of these indirect ways of interfering with the hepatitis C life cycle definitely put the virus into harm. They make it, they work, and so in principle that's fascinating. The biology is fascinating. The practical issue is that some of these early medications from these classes have had some trouble with safety, and there have been some safety signals, and with the other medications coming out being effective without safety signals, it's not clear to me what the future is for those other classes of medications. But I think the story with HIV would tell us that it's better to have a lot of choices, and the more weapons that we have, the better. So I'm certainly hopeful that additional drugs from these classes will come forward.
What is the best treatment for genotype 4?
Well, genotype 4 infections dominate in Egypt and some other parts of the world, and they act a lot more like genotype 1 than the other genotypes. Right now, the standard of care is the use of pegylated interferon, ribavirin, for genotype 4 infection. There are also some studies now looking at these new agents, and some of the new agents are actually pan-genotypic. Once again, we might be able to foresee a day where we don't have to fret about the genotype, where we're working with medications that are genotype non-specific.
Okay, I've got a couple of other questions here. What are the drugs for hepatitis C, and what is the most effective? I guess it's drugs,
yeah,
but it's misspelled.
For those of you watching, we're looking at a font about this big and trying to read your questions. We apologize for the technical issues. The current standard of care for treatment of hepatitis C today, the U.S. FDA-approved treatments for genotype 1 hepatitis C are pegylated interferon, ribavirin, and an HCV protease inhibitor. The standard of care for the other genotypes is pegylated interferon and ribavirin. That's where we stand today. and we're hopeful that in about a year and a year and a half, we'll start to have some new options.
Okay, I think we've answered all the questions. So I think we're ready to complete our interview. Dave, thank you for joining me for this discussion of hepatitis C. Also want to thank Genentech and Cubis for the support for this educational series. Please remember to complete the quiz at the end of the session to get your CME credits. I'm John Bartlett, and thank you for joining us.